Hello friends, welcome back to my channel with a new video on the part 2 of meningitis which we left last time, uh, where we actually covered what exactly is meningitis and what are the causative organisms which can lead to meningitis. Now in this particular talk, let us discuss with the risk factors and how can we diagnose, what are the CSF findings and the role of imaging. So these are the certain risk factors for development of meningitis. As I already said, extremes of ages, diabetes, which forms a important risk factor, chronic diseases like CKDs, the CLDs, COPDs, and so on and so forth. Alcoholics, of course, as we know that listeriosis can have usually the predilections for the alcoholics, especially due to the immunocompromised states. And of course, the other immunocompromised states, especially when the patient is on steroids or other immunosuppressants, the collagen vascular diseases, the cancer chemotherapy, etc. Cancer per se can also be a risk factor. HIV actually can come everywhere, and it is one of the important cause as a risk factor for meningitis. Patient with splenectomy status, and of course, the immunosuppressive drugs which we have actually touched upon. What are the clinical presentations which we actually look at? They can either be presenting as acute or subacute or sometimes even chronic. And there are signs and symptoms suggestive of upper respiratory or gastrointestinal tract infections. They may present with severe headaches, irritability, high grade fever, nausea, vomiting, or most of the times they may present with altered mental status, photophobia, the neck stiffness, which may or may not be classically felt, seizures in few situations, of course, uh, usually when it is associated with meningoencephalitis, rash. Sometimes they can also present as coma or focal neurological deficits. As I said, what can be the diagnostic modalities, and of course, CSF, which is the first and foremost, and it is at the forefront of diagnosis of meningitis. And we usually look at the opening pressures when someone does the lumbar puncture. And mind you, it is very important and imperative on a clinician or intensivist's uh, part to make sure that the patient does not have a raised ICP before a lumbar puncture is done. So, of course, you look at the appearance of the CSF, the cell count, the differential count, glucose, proteins, the gram stain, especially, of course, in a patient with the bacterial meningitis. Culture and sensitivity, we may look at CSF lactates, especially in the post neurosurgical status, and we'll touch upon that in my next video. And of course, the CSF procalcitonin. And as I said, these are the various findings in a different causative etiological agents. So as you could see that the normal opening pressure is somewhere between 5 to 20. And let us talk about bacterial meningitis. It is the opening pressure is elevated. The normal leukocyte count in a CSF is less than 5, but in bacterial it can be more than 200. Of course, the differential counts would be predominantly neutrophilic in bacterial meningitis. Proteins are high, so they can be, even more than 100. So the normal range is between 15 to 45. The glucose, which is normally between 45 to 85, and in bacterial, because the bacteria uses the sugar for metabolism, the glucose in the CSF is low, and of course there can be a setting where the cultures are positive. So by and large, we may actually remember as sugar which is less, proteins which are high, and of course the cells which are high. So uh, they can also be a high leukocyte, even more than 1000 at times. As compared to that, in viral meningitis, the opening pressures can be normal or even slightly elevated. Leukocytes can be in the range of 25 to even up to 2000. Earlier on, they could be neutrophils, but in the later stages, the cell predominance could be of lymphocytes in viral. The proteins are high, the sugars can be low or normal, and of course, cultures or the bacterial cultures can be negative. As far as fungal meningitis is concerned, the opening pressures are elevated. Cells or the leukocytes can be between 10 to even 1000, and of course, with a lymphocyte predominance. Proteins which are high, sugars are low, and there can be positive fungal cultures. As far as tuberculosis, and especially in India, we cannot forget tuberculosis, and it can actually be a common reason of or a common cause of meningitis, especially in our part of the kind of third world country or Asia. Opening pressure can be variable. You can see leukocytes again in the earlier stages, or the cells which we say can be between 10 to 1000, and again it could be lymphocyte predominance. Proteins can be very high, sugars are low, and typically they can be a positive AFB cultures, especially if the patient is immunocompromised, like say in retrovirus or HIV status. So this is a good snapshot of what are the variables and how do they differ as far as the etiopathogenesis is concerned. Of course, we can take help of other modalities when the CSF culture is negative, and here we are talking about the bacterial meningitis. We can go ahead and do a latex agglutination or an antigen testing, and of course, the PCR based test will form an important chunk of the diagnostic modalities which are available as our armamentarium against the diagnosis of meningitis. And the advantage, of course, is a decreased TAT, uh, and but the disadvantages being that the cost is quite exorbitant. So in one particular case, in one individual case where the patients are affording, you can definitely go ahead and do the PCR testing. Now, what are the contraindications to immediate lumbar puncture is of course increased ICP with the neurological deficit. If there is recent seizure episode or the severe obtundation, coagulation disorders, local skin sepsis, especially in the area where the lumbar puncture is performed, and of course hemodynamic instability. So all these clinical conditions can pose a problem as far as the lumbar puncture is concerned. And coming to the radiology and the imaging, where the first and the foremost and the commonest thing to do for these patients who have suspected meningitis is advice for a CT scan. But they can be actually advised in any patient who has prolonged comatose condition, those who have seizures, and of course we may actually repeat it after 72 hours after the start of the treatment. And if the patient has excessive continuous irritability with focal neurological deficits, if they have persistent abnormal CSF findings, and of course if there is recurrence of meningitis, to look for any other causes which are missed in the earlier episodes, like say brain abscesses or something like that. So I think here I'm going to stop, and we'll discuss with the treatment modalities in my next video, along with the post neurosurgical meningitis in my next and the final video. So that's all for now. Thank you.